All right. So our next presentation is going to be by Dr. Stephen Welch. So Dr. Stephen Welch is a medical oncologist at the London Health Sciences Center and director of the Baker Center for Pancreatic Cancer. He specializes in advancing national standards for pancreatic cancer surgery and chemotherapy with a focus on evidence-based protocols, including neoadjuvant and combination therapies that improve survival and quality of life. So thanks so much, Dr. Welch.
All right, thank you very much. Great to be here. I feel like I've been talking all weekend and you talk some more. So from protocol to progress, really, I think the purpose of this session, you're not going to get a whole. I think this session, this meeting has been great. A lot of really new information, a lot of different topics yesterday, going through innovations in chemotherapy and neoadjuvant therapy, genomics, etc. It's not going to be too much more new information here. I think this session was more meant to be sort of a consolidation of what we've had, and Craig's cause, I think, is doing the right thing to work towards some like national standards, and I think that the purpose of this is really to bring together some of the things that we've already been talking about, a few things that are new, but to talk about the standards and guidelines that all currently exist, how they can be improved for surgery, for chemotherapy. I'm a medical oncologist, so surprise, I'm going to be talking about chemotherapy. And the regimens that we have, what might lie in store in the years ahead, and integrating all of this in sort of multidisciplinary teams. So this is what we're going to focus on. Stephanie is going to interject. She's got questions and talking points. So she's helping me sort of moderate this session here. Okay, so again, speaking to the standards and guidelines that currently exist, I'm going to talk some about neoadjuvant therapy for localized pancreatic cancer, and decision making with regards to combination chemotherapy for patients, both being treated with neoadjuvant intent, but also for metastatic disease, multidisciplinary pathways, and sort of implementation towards this, sort of a national standard, how we can come together such that a patient that is diagnosed with pancreatic cancer in Vancouver or Montreal or Sudbury is not going through a totally different experience in different locations. So here, as we talk about national standards, have to appreciate the fact that one thing that's probably important is that we not necessarily reinvent the wheel. So I think as in many cancer types, each province has taken on ownership of clinical practice guidelines to varying degrees. So I just kind of did some quick Google searching in terms of, so I know I work in Ontario, so I know what Ontario does. So Ontario Cancer Care Ontario does have a program of evidence-based care guidelines, clinical practice guidelines. Part of the challenge with the PEBC is it's relying on volunteer physicians through some of it, and the documents are great, but they have to be updated. And so I think many of us, me in the room, have probably participated in this process. It's great, and then it's just published. We usually publish it in a journal. It's on the website. But then after 10 years, somebody needs to update it. And so it's a fair bit of work for the PEBC. They want to address the most important aspects. So I can say for pancreatic cancer, what currently exists are two documents. One relates to surgical practices. which is just being updated now. It was a 2015 document. And the second document is adjuvant chemotherapy for pancreatic cancer. There have been others in pancreatic cancer, but they've been archived. So again, there's in GI cancer, there are a lot of different guidelines that they have to address, and maybe not so many people to be doing them. So maybe some gaps there. BC, they have I often will go to the BC Cancer for specific regimen guidance, exact doses, what the ancillary medications are. They do a very good job of that. But in terms of practice guidelines, in terms of when you should do this, when you should do that, I don't. They don't do that quite as well. Alberta, I've listed the website there. The AHS does have some, guideline recommendations for multiple tumor types. Nova Scotia has a diagnostic pathway. I think that's my search was not exhaustive. I didn't look into absolutely every province. Much of what is on the websites are resources that are meant for patient and caregiver consumption. So it's kind of written at that level. In addition to all of these, at least as it relates to GI cancer, there are regional consensus conferences, and made mention of this yesterday. For example, the Eastern Canada GI Cancer Consensus Conference. There's one in Western Canada as well. It used to be solely colorectal cancer, which made it an easy acronym because it was Eastern Canada Colorectal Cancer Consensus Conference. So it was EC5. They made it easy. But now, since it's past colorectal cancer, they have to put GI in there somewhere. So it's EC4 GI or something like that. So so that already exists. But I do think that there is room, and I think that Craig's Cause is taking this up to sort of develop some, national standards. And we talked yesterday about the diagnostic pathway, the treatment pathway. So I think these things could really augment what currently exists. I don't know, Stephanie, if you wanted to add anything to that.
I'm probably going to put Jessica Heat for this. Jess, she was working with a lot of the different pathways that we see up there when she was. So, and we had a working committee that was working with us on these national guidelines, because somebody said something yesterday that resonated with me, and we've always said it, and I can't remember their quote, but really, why should some people get certain treatments that others can't, depending on the province that you live, which is where this all started from. And also just the feedback from everybody saying that they use these different documents. Jess, are you there to talk about some of the other documents that you looked at? You just texted her? So they're all relatively the same. Found interesting that they're all presented different ways. So some have these flow charts that were really past my ability to even read. And I thought, well, I can't be the only one. Maybe I can't be the only one that would have a hard time looking at those flow charts. So that's why we just thought we would start numbering items. So, 1, 2, 3, and then go to 5 or go to 7. So when we were looking at all these, we saw the graphics, we saw the written documents. They're relatively similar. Everyone knows that you should see a surgeon, a medical oncologist, but a lot of things that were missing was the management of pancreatic cancer, for instance, and the treatment. When we did the first pathways, Onivide was a part of it, and now we have to do a little bit more investigation in that. We've heard about PERT. So in the management part of the pathways, PERT isn't in many of the guidelines. Mental health. We talked about yesterday at our table, access to a social worker, the nutritionist component of it, making sure we see a nutritionist. So the diagnostic pathways aren't that different. It's just how they're presented. And depending on the province. So PEI can't see a surgeon. PEI has to go to Nova Scotia. And we're also dealing with, when we're trying to make an equitable pathways, how do we make sure that Northern Canada, where do they go? And then someone made the recommendation that there should be maybe a list of cancer centers that are recommended, so that even the wherever the patients first present, that they have access to a list of cancer centers that are accredited. That's not the right
Yeah.
word. Accredited.
I think everybody knows what you mean.
Yeah.
But yeah, I think that's
Like, those are certain things that I think we have to make sure in the pathway. So the diagnosis is pretty much the same. It's the management and treatment we found that needed a lot of support and new wording for it.
Yeah.
And Jess just said a big gap in the diagnosis is covering all the different entry points: pharmacy, nurses, primary care, and ER.
Yeah.
And Jennifer Knox talked a lot about that too, where pre-COVID, people that came into the ER that presented with possible pancreatic cancer diagnosis, they would have the biopsy done before they left the hospital.
Right.
So that they weren't lost in the system of referrals and delays, and she would like to go back to that. And that made us also thinking, and I think that was reflected in the pathways as well, as once the patient leaves the hospital, Dr. Knox was saying, then we're looking at those wait times, like from the first symptoms when they first presented to actual starting of treatment was the delays too. So we're trying to make sure that's reflected, but still equitable, and people know where to access that care if they can.
Yeah. I mean, I think that I think we have to appreciate in this country, how there is such regional variability. There's geography, there's, how institutions are set up. Each province is in charge of their healthcare. So I think that that's one of the challenges that you face when coming up with some kind of national guidance, is that you do have to respect the fact that provinces are in charge of managing their healthcare. That's what's in the Constitution. So, but that doesn't mean to say that on a national level there can't be some guidance to all of the provinces, and I think that that's where they're, and I think we have to, I think what Craig's cause should be focusing on is the gaps. Where do the clinical practice guidelines currently not really address things? And perhaps it shouldn't be so prescriptive. So the example that you just gave about, at UHN, it's keeping the patient in to get that biopsy before sending them home. I don't know that you necessarily want to be that prescriptive, but to say that, a patient should go from suspicion of cancer to diagnosis of cancer within X amount of time. And each region, each center should figure out what is best to achieve that goal in their jurisdiction. But to set targets like that in terms of, best practice is to have the suspicion to diagnosis in X amount of time, diagnosis to treatment in X amount of time. And then each region can, I think one of the things that should be valuable in bringing people from across the country together is sharing best practices on how they've achieved those goals over time. So just
I think that, and I think that's exactly where we're going with this pathways, is even though some of the items that are suggested in the pathways, I keep going back to palliative care, but we look at, just access to medical oncologists or surgeons. If we don't have it down as best practices, then we can't advocate for it.
Yeah.
And if people aren't making those referrals, then we can't say this number of referrals were made, but the patients didn't have access to the care. So I keep going back to that as well, that without a consensus on best practices across Canada, even though right now we know it's not equitable, it's a foundation that we can start advocating for.
Yeah. So I would just, I guess bottom line to this is although there are, I've kind of heard this in, not necessarily for pancreatic cancer, but in other areas, why should we bother with some national standard? Because it's up to the provinces to decide what they do. I disagree with that. I think there should be some national guidance. Understanding that there's going to be provincial variability, but we should be seeking to reach a standard for the country. So
Documents they're using are national standards in other countries.
Yeah.
You know what I mean? Like it's, so you can use provincial, but some of the documents like the ASCO documents, those are best practices.
Yeah.
You know, that are used in the.
Don't necessarily have to reinvent the wheel.
Yeah.
SCO, ESMO have guidance documents too. So yeah. Anybody else have any thoughts on this? We only have one microphone. So, oh no, there's on that microphone. Okay, yeah.
When I was looking for a pathway map for pancreatic cancer several years ago, I did find that Australia had a rather comprehensive one, and I did share that with Stephanie.
Okay.
That was kind of interesting because I looked all over the world to see who was already doing this. Because in Canada, we do this for several of the main cancers like breast cancer, colorectal, lung cancer, but not for pancreatic cancer. I thought it was very interesting what Dr. Leslie said yesterday about how we need to recognize who the target audience is for this pathway map and consider, you know, is the doctor going to use this? How will this help support the work that we're trying to do? And that's a question that we probably need to answer. So
Yeah, that's a good
anyway,
point. Yeah. And yeah, I think, you know, I could envision, yes, certainly this could be for the healthcare providers to make sure that they're sort of adhering to these things. But I think it's these documents are also important to the policymakers, you know, because I think that if these are our standards that we want to achieve, well, then we need the resources to be able to achieve that. So, and then that comes from the cancer agencies and such. Yeah.
Yeah, thank you. I've been sort of going around in my head about some of these things as you guys have been discussing. I think that broadly speaking, when you think about national standards and guidance, I think that's a great thing. I think that so two things. I think when it gets down to the level of pathways, that's why we see them at provincial levels, because pathways need to be implemented. And so they need to take in the context and the nuance of what's happening at a more local level, right? And obviously we don't have national jurisdiction over healthcare. So to me, there's a difference between national guidance and standards and the actual pathways. Yeah. And so I think that pathways in many ways, not that there couldn't be a broad framework around pathways for sure, or guidance, but they really do have to take into account sort of provincial constraints, considerations, context, resources, and all of that. So, you know, Nova Scotia will look very different than Quebec or British Columbia and so on in terms. So I see them as different. So I think national guidance and standards are really important, probably particularly in pancreas, because I don't think we do have a lot out there compared to some other disease sites. Then the other thing I think about, and I do think they're very helpful for like cancer agencies and CAPCA and so on. The other thing that comes to mind as you were sort of then speaking, I thought like we do have an organization, and you know there's pros and cons to it. I'm not, but there is an organization that's meant to sort of come up with standards and guidance broadly speaking nationally and share best practices, and that is CPAC, the Canadian Partnership Against Cancer. And so I don't know if there's any efforts. I don't think they've done a lot, other than maybe some centralization of surgery. They haven't done a lot of pain in pancreas cancer. I don't know if there's any thoughts around, you know, working with CPAC around some of this stuff. I take your point, being involved in a lot of this stuff on the East Coast. I take your point that, you know, whether it's provincial or national or even the CPAC, this is mostly always done off the side of someone's desk. And so that's a really hard thing to sustain. Like it really, and so the maintenance and the updating is really hard, whether it's provincial or even national, right? Because the people who are working with CPAC are still employed in their jurisdictions, and this is something that's being done largely off the side of their desk, you know, except for their core staff. The other thing that strikes me through today and yesterday, and I don't know if this is the time to bring it up, I was going to talk to Stephanie later about this. I was just involved, and it took a long time, like the idea to really getting work on it probably took a long time, but then the work took about 18 months. And I was sort of like helping sort of develop the National Lung Cancer Action Plan, Pan-Canadian Lung Cancer Action Plan, which was just launched 2 weeks ago, maybe in Calgary. And that was 18 months of a lot of work of people engaged in and interested in lung cancer across the country. We need it. Lung cancer has a really big burden in Canada. And I think, Stephanie, your comments yesterday and other people's comments around the mortality burden of pancreas cancer, right? Might also be like, that's a strong justification for me to think that we need a similar action plan for pancreas cancer. And I say that a big part of, I think, in the discussions around CDA and all that, just sort of side discussions I've been having, sort of thinking about the evidence that still needs to be generated. Like there needs to be a research pillar, I think, and then that needs to flow right to where patients are and to patients and families. And so just to put that out there, it's a lot of work. It involves bringing together a lot of people, but it can be done. Like, and I do think it's like, there are goals now that are set around lung cancer over the next 10 years that organizations, including the Canadian Cancer Society, have said we're committed to, and we're going to meet those, like reducing mortality by 30% in the lung cancer space. It's different than pancreas, but I'm just saying there's set goals that now, the country is trying to achieve. So I'll just put that out there.
Yeah. Well, thank you for that. I think, I think that perhaps kind of I think I like the word action plan. I like that phrase because I think that again, I agree with you that I think being really prescriptive and getting into the weeds on the pathway where, like it or not, like yes, I understand, like as I said before, a patient who just happens to live in Vancouver versus Sudbury versus Halifax, should get similar care, but Vancouver is not Sudbury. Vancouver, like they are different places, and so it is like I think it is up to the jurisdiction to get sort of into the weeds on the pathway, but they should be adhering to a higher order. Right. And I think that's kind of where lung cancer action plan is going. And I guess the other thought here is that yes, it takes a lot of effort to build a document like that, but it shouldn't end there because new information comes all the time. And so I think that it has to be almost like a living, breathing document that is updated on a regular basis, maybe at meetings like this one. So.
Yeah, that's a great point. The updating and the maintenance, I'm calling it, but the updating is really difficult because I feel like you underscored how much work it is, even when you said it's a lot of work and you've been involved in like the PEBC here in Ontario. I just like, it is a lot of work. Like that Nova Scotia diagnostic pathway for pancreas was years of work. And then all of a sudden, and Nova Scotia's got, I think, 8 different disease site ones approved now, but like that started years ago. And now we're finally getting to a place where they're being approved and put out there. So it really is a lot of work. So I think your idea of like coming on to this conference or whatever and like making that the time when you do some updating and is great. The only thing I wanted to say also just in the lung cancer space, the reason, interestingly, really a long time ago, I really got it. Well, I'm interested in lung cancer. I've had people in my family with lung cancer, like I do cancer work, but it really was around access to care, access to these new emerging technologies that are coming out, targeted therapies, diagnostics, and so on. And I was working with a person with lung cancer experience that I worked with for a long time in Atlantic Canada. And about 7 or 8 years ago, she said to me, and this drives my thinking around the action plan all the time. She said, my greatest fear when I was diagnosed was that I would not have access to the therapies that I needed to manage my disease, and so on, that people in Toronto or Vancouver would have access to because I live in rural New Brunswick. Mm. And that was my greatest fear when I heard I had lung cancer. So I think that's very similar to pancreas cancer and so on. So I think like nationally, I think there is opportunity to work on equity and and
Yeah.
sorts of
Yeah,
things.
no, that's a great point, and I think that's something that somewhere in this standards document addressing that there should be equitable access to specialist care. Exactly how that looks, I'll have to say. I was concerned I was not going to have content for an hour and 15 minutes. I have one slide and it's been going for half an hour, but this is good. Keep up with the, yeah.
Sorry, Jim, Jessica, heavily pregnant, still at home. Thank God she's still pregnant. She might not be after today. And she said, and how the treatment and pathway leave for the patient's wishes and values? Does it ever come up that patients who are eligible for surgery opt out of it? For example, yesterday was mentioned that germline genetic testing is highly valuable for relatives to have knowledge of their family history. However, it was mentioned on Friday evening that familial pancreatic cancer is so rare that family history should not affect the diagnostic pathway. So it seems like there is room for discussion in this area before reaching a national consensus. That was from Jess. And then I do like what Robin's saying. And maybe we're calling it a pathways when really it should be called, a best practices, guidelines, or
Standards.
what did you call it?
Um,
Oh, it's past.
Action plan,
Action
standards. Yeah.
Yeah. And then I was thinking another thing, sorry, Jim, is before my menopausal brain gets it. Oh crap, it just happened. Well, it's past. Jim, go and it'll come back to me.
Sorry, just putting on my university hat. So really great discussion. When I think of standards and sort of that higher level, I think of what should happen. So that's kind of the pieces. And then when you get into how it should happen, that's the details that the provinces need to deal with. And just some past experiences, if you go to a province and say, this is how to do it, they'll say, well, I'm not doing that. Or they might say that we don't have the resources, or they might say our context, that doesn't work. So kind of that land of pilots that Canada is, and then going across. So that's the how. And then the best practices are, there's many different ways to do the how within the context. So if you have a collection of those best practices, then people can take what works for them in their context and then implement, and that becomes the pathway. So I don't know if that's helpful,
Yeah.
but just sort of how I would think of it.
I think no, I think that is perfect. But it's that piece of sharing the best practices. I think that's you need a forum where you have access to those shared practices and how that actually gets shared. We each have like different organizations. I'm president of the Canadian Association of Medical Oncologists. So medical oncologists have an organization. CAGS has a surgical organization. So uniting for those people who treat pancreatic cancer, I think there needs to be a forum for that too, that connects regularly to do that sharing of best practices.
And then just the other comment on standards is around, and I heard the word earlier around accreditation. So is there any piece within those standards with Accreditation Canada or other organizations that might be able to help? Because again, they have the processes in place of how to do that. So
yeah,
that might be something that's helpful.
That's a helpful thought. Yeah. Okay.
Going back to what Robin said too, is like, these are all huge beasts to create, like it's a big project, but a lot of the people that have been creating it often have, like you look at Ravi or any, like, it's a big job in and itself. But, the next session is on recommendations moving forward for, the next year and a half before the next conference. Like we want to have that working year. I've been talking to some of the industry partners, and really, if we could allocate one person in charge of not only whether it's best practices or looking at equitable access, but then following through on equitable drug access. and being more proactive. You know, if we have these best practices guidelines and we know, especially with drugs coming through the pipelines as well, having that person working on the documents, working with all the organizations that we've mentioned before. Just one, bringing all the GI organizations together, along with CAMO, CAGS, you know, I think you said EC5.
Yeah.
Or, you know, so getting everyone on board, signing off on the document, and then using that document in terms of drug advocacy as well, once you have those best practices.
Yeah, and organization that's probably been brought up and I missed it or whatever. But in the context of some of the afternoon's discussion and the is CAPO, the Canadian Association of Psychosocial Oncology, which I think in the context of the survivorship and just everything we're talking about in terms of supporting patients and families.
Add one more thing, and I don't know, again, I'm a newbie, so it might be just right over left field, so I can ignore it. But I had the pleasure earlier this year of going to CIHR, ICR conference, and they told me it was the first time, I don't know if it was, but I was part of a 3-day workshop, and it was the first time that they brought people from all the different disciplines that we've just talked about, put them in a room and said, we need to solve this problem. And it was just 3 days of work. That's all it was. But they came out of that with like amazing documents. I just couldn't believe what they came out of in 3 days. And just bringing all the people together. You know, they had psychologists and dietitians and surgeons and oncologists to talk about. It was all focused on survivorship. But it was kind of interesting. So not saying necessarily that they need to back it, but I think it's intensive. It would be a great kickstart for something that you're trying to do.
Okay. So I'll switch gears to just a couple of slides on surgery. We had some good talks yesterday on surgical management, but I think it's pretty obvious to everyone in the group. Surgery is still the only curative intent option for patients with pancreatic cancer, and we've realized for quite some time that centralizing this highly specialized surgical procedure, Whipple surgery, at high volume centers is associated with better outcomes. This is not new data. It's from quite some time ago, and that is in a PBC guideline from CCO, and it's repeated elsewhere. That said, there is an increasing shift towards neoadjuvant therapy for localized pancreatic cancer, where there's a risk for a margin-positive resection. A margin-positive resection is a poor outcome and associated with poor prognosis. So, again, in terms of localized pancreatic cancer, that can be split up into resectable disease, borderline resectable disease, and locally advanced but unresectable disease. And much of that relates to the proximity of the tumor to important blood vessels. And there are accepted resectability guidelines, the AHPBA, NCCN, both have guidelines. They differ a little bit, and different jurisdictions, different surgical groups will take on different guidelines. But I think adhering to these guidelines in how we're describing the status of a localized pancreatic cancer is really important. So on the right here is just, this is a meta-analysis suggesting, so over to the left, neoadjuvant chemotherapy is better. To the right, surgery up front is better. And any of these lines that sort of touch that middle means that we're not really sure one approach is better than the other. When you pool a number of studies together, you have the power to be able to say whether this is something that is helpful or not. So for borderline resectable, based on the meta-analysis here, neoadjuvant therapy is certainly of value from a survival perspective. Still not quite certain in the upfront resectable population whether this is neoadjuvant therapy is indeed the right thing to do. That said, I think I was talking at the break that I think most major cancer centers in the United States have adopted a neoadjuvant therapy approach. Many centers, including ours, have taken a neoadjuvant therapy approach for most patients diagnosed with pancreatic cancer. But I would have to at least admit that this is at least a little bit more controversial than it is for the borderline resectable patient. And there are 2 large randomized controlled trials looking to address this. And you heard this from Dr. Gill yesterday, that the one that Canada was involved in is closing soon. That's the Alliance trial. And Pablo Serrano spoke about this as well yesterday. So hopefully that gives us some definitive evidence for or against using neoadjuvant therapy across the board. So I think that likely when this group meets again in 2 years, there might be something that's much more definitive in that space. For the medical oncologist, what we look to for neoadjuvant therapy in most of the trials, modified FOLFIRINOX is what is incorporated. There was a study, PREOPANC2, that looked at modified FOLFIRINOX compared to chemoradiotherapy. That study didn't show a statistically significant difference between either approach. Gemcitabine nab-paclitaxel, I put an asterisk next to there because we will often use that as an extrapolation from the data for gemcitabine and nab-paclitaxel in advanced disease. It's in Ontario, at least, if we label it as neoadjuvant therapy, they don't like that because it is not, it's listed as a first-line metastatic regimen. So we get into a little bit of wordsmithing when it comes to access. I haven't had personally any issues with it, but it is a little bit, in my view, of an unnecessary barrier to get access to gemcitabine nab-paclitaxel in this situation. I don't know if that is something that is a problem anywhere else in the country, but there you go. So I think in terms of what we should be talking about in terms of a standard document, I don't think any of these things are controversial and couldn't be applied across the country. So I think all cases of localized pancreatic cancer should be discussed at a multidisciplinary case conference. I don't think that that's controversial at all. And I think centers should adhere to this internationally, not just nationally. For that decision-making at multidisciplinary case conference, you should have CA19-9. That's an important marker. And you should have high-quality imaging. And, what does high-quality imaging mean? Well, I guess it kind of maybe depends on the institution. It depends on what expertise in radiology you have. So I don't necessarily want to be prescriptive there. But I would argue you really also need to have a radiologist who is expert at abdominal imaging as a part of this multidisciplinary team, because the radiology is absolutely critical in this decision making. So I think that has to be emphasized. And I put here that neoadjuvant therapy should be recommended when there is a high risk of margin positive resection based on the preoperative evaluation. So exactly where people put that bar, whether they use the AHPBA guidelines or the NCCN guidelines, where they have a different threshold with regards to CA19-9. I wouldn't recommend being prescriptive here nationwide, but I think a statement that says if you are concerned that this will be a margin positive resection, neoadjuvant therapy would be recommended. I don't think that that's controversial either, but happy to hear from others. Lori, you have a comment? Mm-hmm. What's your question? Yeah, so I mean, I think that we could, I guess certainly if neoadjuvant therapy is recommended, there should be a biopsy beforehand. I could understand that if the decision is to go ahead with resection up front, that a biopsy may not be necessary. Is that fair, Ken?
That's fair, though the genomics and the germline, et cetera, we were talking about yesterday, may change that over time.
Right, yeah. So I guess if that second bullet there, if factoring into decision making is genomics and information from the tumor, and that helps to guide decision making about resection or not, then absolutely, I guess I would say biopsy tissue diagnosis needs to be there. Yeah, yeah. It's very, again, in our milieu, I can't remember the last patient, Ken, that would have had no tissue diagnosis, just goes straight to resection. We were talking about this yesterday. It's very uncommon, but I could understand a scenario where that might be the case. But I think as we get more information about the importance of genomics in these cases, a recommendation towards biopsy preoperatively would make sense. Any other thoughts on that?
Abby's just writing right now. Robbie wrote this thing, so he's just.
I'm sorry, you say it again? I'm going to get to that.
Oh.
But at this pace, I don't know when we're going to get to that. Okay.
You keep going and I'll enter when Ravi's finished typing.
Okay.
Away.
Okay. I'm now very curious as to what Ravi has to say. Okay. All right. So I have to share this with everybody. If you Google JCO Stephen Welch, you get this is my first and only first author publication in that journal. 2007. It's an editorial. Malcolm Moore was one of my supervisors, as well as at Princess Margaret. Combination chemotherapy in advanced pancreatic cancer. Time to raise the right. Is it time to raise the white flag? This was an editorial of, and I think that Dr. Gill mentioned this yesterday. This was at a period of time where we had a myriad of studies that were gemcitabine versus gemcitabine plus something else. And this was yet another negative clinical trial of you take a pancreatic cancer and it's randomized gemcitabine to gemcitabine plus X. And so these were my words. Time to lay down our sword and concede that this future, the better future for pancreatic cancer, will not likely be found further evaluating combinations of cytotoxic agents. Nostradamus, I was not. Now, I wasn't completely nihilistic here. I think that in much of the paper it was talking about the fact that we need to leverage what we know on the biology of the disease and tailor our treatments towards that. And so we haven't realized that enough yet, but I think that future is there. But clearly combination chemotherapy has made a difference in this disease. So just a few years later, just had to wait a couple of years. Yeah.
I did get a response from Ravi.
Okay.
So Ravi said, I think all cases should have a multidisciplinary case review. Some can be done at a tumor site. Sometimes it can be done via email. Some sites do not have enough slots to review all the cases. So I would say need a multidisciplinary review of the case. Which is, again, we're talking about the overburdened system.
Yeah, no, I mean, I think that's
fix that.
I think it brings up a good conversation because this is something that we're grappling with in London all the time is that the radiology reviews, we're asking for very thorough radiology reviews and lots of patients. It's a time burden, etc. And certainly some cases can have that multidisciplinary feedback without the in-session, meetings such. But I could imagine if I was a patient, why did that patient get the full meeting and I didn't? You know, so I think unless we have some pretty clear criteria of what the decision there is, I would push back a little bit on sort of fast tracking or streamlining some cases. I think that that's something that it would be interesting to have a working group kind of look at how MCCs should operate, because it is a challenge. It is a challenge as we're seeing more of these, and we have these more difficult discussions on neoadjuvant versus not of how to grapple with this. But maybe we can be doing it more efficiently.
And I also see it in other diseases. So I think I was sharing with you, my mom had been in the hospital, and to get on, she had, I think we counted 6 different specialists that were on her case.
Yeah.
To get them all into a room and discuss mom's case was monumental.
Of God.
Like it was a very challenging, they were just aghast that we were requesting that multidisciplinary meeting. So I do know, like, I understand I think we have to have that expectation that all patients get it, but we also know, so putting on my advocacy hat, we also know, and my daughter's in her last year of pharmacy, so she's sitting in on these multidisciplinary reviews. And she said at these, review sessions, it's highlighted whose families are advocating.
Mhm.
And so it goes back to your point of, we should all have the same standard. But I think with an overburdened healthcare system, some people are getting a better standard of care than other people. And how do we address that as an advocacy organization? Like we always say to our patients, this is how you become an advocate for your loved one. Often because the person who has the disease isn't able to advocate for themselves.
Yeah.
But it's, yeah.
I mean,
discussion.
it certainly could be rephrased as a multidisciplinary consultation. I think it's just not. I think what we want to avoid is patient sees a medical oncologist, and the medical oncologist just assumes that surgery is not the thing, and they just go ahead with that. And surgeon, same thing. So I think that there needs to be a demonstration of a collaborative, what do they call it? A collaborative conversation at minimum that's documented. Does it have to be the formal MCC? I can understand.
The standards document? No, not pathways, maybe, but standards.
Standards document. Yeah. So we may have to, I'm interested in people's thoughts, but whether that notion of, what did I put here? That I said it wasn't controversial, but maybe it is. Where is it? No. Did I pass it? Yeah. So that first bullet of discussed at multidisciplinary case conference, might that be modified to incorporate what the point that Ravi was putting out there, that there needs to be at minimum I don't know about wordsmithing that, but there has to be multidisciplinary involvement.
You have out of the web.
Yeah.
Depending on resources.
Yeah. So, okay. So, any other thoughts on that? I don't want to, anything online? No? Okay. So, in terms of systemic therapy, these are our go-tos: FOLFIRINOX and gemcitabine paclitaxel. Oh, I'm going to move my mug out of there. So FOLFIRINOX does improve outcomes compared to gemcitabine and nab-paclitaxel based on, this is everything on this slide is actually Canadian data. So Kelvin Chan did do a retrospective review in Ontario, suggesting that the patients who were treated with FOLFIRINOX did seem to do better than the patients who received gemcitabine and nab-paclitaxel. Careful about retrospective studies, because it could be that the most healthy patients went on to FOLFIRINOX, the least healthy patients went on to gemcitabine and nab-paclitaxel. So certainly not a randomized trial. The modified version of FOLFIRINOX is generally in use now. Not to get into the weeds, but the standard FOLFIRINOX that was used in the metastatic study uses a bolus of 5-FU and a higher dose of irinotecan. That is associated with much more toxicity, and we have data. Jean Maroon published this over 10 years ago. I think there was a Dr. Svetkova on that paper too, maybe. Or maybe it was a subsequent paper. I don't know, but suggesting comparable outcomes in their retrospective review and with reduced toxicity. So I think it's fair to use modified version of FOLFIRINOX in the neoadjuvant setting, in the adjuvant setting. So definitely in adjuvant and neoadjuvant protocols going through now, they're using modified FOLFIRINOX. Gemcitabine and nab-paclitaxel. There's a study that was published by the Queen's Group in JNCI Cancer Spectrum, at least at the time that they were looking at it with the cost of nab-paclitaxel at the time, that gemcitabine nab-paclitaxel was more costly to the system and very well may have been less effective in their cost effectiveness analysis. That said, I think this remains an important option for patients where we feel that FOLFIRINOX would be concerning for toxicity with regards to age, comorbidity, performance status. I listed here, as I mentioned before, Ontario does still have some restrictions on how we use gemcitabine and nab-paclitaxel. They make, they count lines, so first line, so the first treatment for metastatic disease. If you choose to use FOLFIRINOX at the start, they won't give you access to gemcitabine and nab-paclitaxel second. I don't know if Ontario is the only jurisdiction that does that. Ravi can put in his text as to whether that happens in Halifax. I think this is completely unnecessary at this point, especially given the limited options that pancreatic cancer patients get. So this needs to be pushed back, especially since compared to when nab-paclitaxel was first introduced, the cost to the system is less. So I think that's just something I think that people higher up have just kind of forgotten about. But I think we should have more flexibility in how we use gemcitabine and nab-paclitaxel. Yeah. I see. Yeah. Now I think all of these decisions that we've made based on FOLFIRINOX, gemcitabine, nab-paclitaxel, they're both active regimens. There are pros and cons to either one. We can, look at concerns for toxicity, age, performance status, etc. But I think what we really want to know is if it's going to work. And so I think that data from Jennifer Knox and the group in Toronto from the COMPASS trial is basically suggesting to us that there are pancreatic cancer patients with this sort of classical subtype that do better with FOLFIRINOX, and the basal-like don't do very well with FOLFIRINOX, and you best to be using gemcitabine and nab-paclitaxel. So I think as this evidence matures, my hope is that we actually have some biomarkers that will tell us which of these two regimens to use for our patients, not just which one we're more concerned about side effects or cost or all these things. So GATA6 might be that marker, but I think we still need a little bit more evidence on that. But hopefully soon we will have a differentiator there that helps in guiding. So I don't know if anybody has any thoughts about that. No. Chris?
Yeah, thanks, Stephen. And actually, this is something that goes to a point that I think we keep on missing. We talk about genomics, which everybody focuses on gene mutation. So far, gene mutations, as far as I know, have not been that indicative of how well the treatment is effective. This analysis right here is more about RNA and protein, which is a molecular analysis, which is on the tumor. I know that we were part of the study, was a NeoPanc1. GATA6, the problem with that is that it's not exclusive to one or the other, but we do have some markers that are.
Yeah.
And so we've been able to do some analysis on some of the samples we have locally to show the specificity of those markers. It may take a little bit more. It may be like analyzing a few, but I think we're set up to be able to do that.
Yeah, and then likely that means some prospective validation of that.
Absolutely.
Prospectively. So no, but it's good that we're moving in that direction. I think that because those two regimens are here to stay. I think it's just a matter of how we use them, how we use them better. Okay, so here's a question about Naliri that came from someone online. Nanoparticle liposomal irinotecan, Naliri Onivide. So this is just a novel way of giving a drug that we have used for disappeared. I'll keep talking. So a novel way of giving the drug irinotecan that's part of the FOLFIRINOX regimen. So there was a study. So basically what that does is it allows the irinotecan to stay in the circulation for longer. So it has a different biologic effect on the tumor. So Napoli-1 was a study that compared in second line, so patients who had been treated with a gemcitabine containing regimen, 5-FU and Naliri versus 5-FUs. It was a positive study. It improved survival, median survival benefit of 2 months with adding Naliri to 5-FU. Now that's to 5-FU alone. I often will give FOLFIRINOX to these patients if they're well enough. So how does 5-FU Naliri compare to doing FOLFIRI or FOLFIRINOX? I don't know the answer to that. It's certainly better than 5-FU monotherapy, but I don't very often use 5-FU monotherapy second line. Napoli-3 was a study where they incorporated the nanoparticle liposomal irinotecan into the FOLFIRINOX regimen. So 5-FU, Naliri, oxaliplatin. And that outperformed gemcitabine nab-paclitaxel in a head-to-head study, median survival gain of 2 months. How does that Nalirifox regimen compare to gold standard FOLFIRINOX? If Naliri cost nothing, we wouldn't be having this discussion. Of course, it's a median survival gain of 2 months, but it doesn't cost nothing. It costs about 100 times as much as irinotecan does. So I think we have to then question, is it worth the cost? Is there there's a value proposition here? So Health Canada and CDA did approve Naliri in the second line setting. It got halted at PCPA. So the negotiations with industry stalled without agreement. They wouldn't come down on the price. We wouldn't go up on the price. So it's a Health Canada approved regimen that has some benefit, but again, I'm still not really convinced myself that Nalirifox is that much better than FOLFIRINOX, which we are using right now. So that's my answer to that question. I don't know if there are other practitioners in the audience here or online that have a different, this is just coming from me. There could be others that feel differently about this, but yeah.
Ravi's saying, poor Ravi, he's tired. Makes sense. He might quit. Ravi's, yep, and they will unlikely get it available to. Company has stopped trying to get it covered. Too costly. Do not think PCA. That must be PCA, or would it be the PCPA?
PCPA, yeah.
The change.
Yeah, I don't think, yes. So I think this is stuck on a cost issue, and I am stuck on an AV issue. I don't know what's
Yep. So one of the comments was not enough medox or space in chemo suite for neoadjuvant treatment for all patients. High turnover of nurses right now. This is for Nova Scotia, and chemo makes, and probably Eastern, or at least Atlantic, I should say. High turnover of nurses and chemo makes treatment challenging. Getting BRCA testing done quick enough to note if it should be a FOLFIRINOX versus Abraxane.
Okay. Yeah. So now as we talk about BRCA, I brought this up yesterday. So just a little bit more on olaparib for BRCA mutated pancreatic cancer. So the Polo 1 study, this was published in the New England Journal of Medicine. Sorry, I didn't put the reference there, but there was a doubling of median progression-free survival in this study. It didn't equate to a median overall survival benefit, but there was a bit of something of a tail of that curve. So if you look at the 3-year overall survival in this study, it was 34% with olaparib maintenance and 18% without. This is a Health Canada approved regimen, but in its first pass. So I actually looked at this last night. So there was a resubmission for this. I don't know who did it. It's like a non-industry sponsored. It doesn't say who, but it was a non-sponsored submission, and it's being looked at in January. And Jim is now not going to be able to. He's like embargoed. I don't know, but
That's exactly right. I cannot comment. But just to let you know, the pathway for a non-sponsor review, it comes from the drug plan. So there's a drug plan in one or many of the jurisdictions that have asked for that review. That's typically how the non-sponsored review happens. So that's the process from that FMEC committee that I showed yesterday.
Okay. Is there anything I'm doing wrong up here where it's not showing up? I don't know, but yeah.
Have you used olaparib much, and what are you seeing in the clinic?
I have used it sparingly. I think it's probably about 5 patients in this setting where where a patient has had response to chemotherapy, and then you're using it as maintenance. One patient that I have has done remarkably well and has been in we can still see that there is disease, but it hasn't been changing for 3 years. I've had lesser degree of response in other patients, again with BRCA mutation. I have another patient that had access to this. He doesn't have a BRCA mutation, but he has an ATM mutation. And I don't think all of these homologous recombination mutations are the same. So I'm pessimistic that he's going to get as much out of this as the BRCA mutation patients. And I think there was some question, I think from yesterday, about whether there's another mutation, PALB2, maybe that should be included into this as well. So and not all BRCA mutations are the same. So I think that's what we're learning. So it's a small segment of the population, but I think there's potentially big, there's the potential for some significant improvements for that small group of patients. Okay. I got to go through this quickly until it goes away again. So I think we have to keep in mind as well for pancreatic cancer that there are tumor agnostic indications. So mismatch repair deficiency, regardless of disease site, pembrolizumab now has Health Canada approval and reimbursement. So mismatch repair immunohistochemistry should be something done on all pancreatic cancers. Should be done on all cancers. Period. NTRK is another thing that it's really, really rare, but NTRK fusion can happen in any cancer, and there's it's HER2, so HER2 trastuzumab deruxtecan is an antibody drug conjugate against HER2, and that got Health Canada approvals.
Joan, you can go ahead and unmute yourself if you'd like.
Sure. Hi, can you hear me? Can you hear me? I can't hear anyone, so I'm not sure if my audio is going through.
Okay, Joan, do you want to try now?
Yeah, can you hear me?
Yep.
Okay, perfect. Thank you. Thank you, Dr. Walsh, for your presentation. So we know that identifying homologous recombination deficiency using DNA and genomic profiling is the bona fide example of personalized treatment for pancreatic cancer. You showed the New England study there. This is more coming from a medical student perspective, so I apologize if it's a bit of a naive question. But if we see that olaparib does improve progression-free survival from pancreas cancer, and although Health Canada has approved it, kind of what are the barriers to then making it covered across Canada? And then second, in line with that is kind of what are the barriers then to getting germline genetic testing for patients across Canada?
Yeah, so good questions and not at all a naive question from a medical student. So I'm gonna have to get your name and watch your progress. The issue of the payer. So Health Canada, and I'm going to paraphrase what Jim did a really good job yesterday stating. Health Canada looks at the efficacy of a treatment and will allow the maker of the drug to sell their drug in the country. That is a different thing than the government public payer being willing to pay the amount that is required. So there is a lengthy process. We're trying to make it less lengthy, but it is a lengthy process to adjudicate whether there's enough of a value proposition for that particular drug and that indication. Does it work well enough, and is the cost reasonable to go ahead and actually put it on the provincial formularies? And so that involves the CDA, then also involves collection of the the provincial pharmaceutical agencies to end up negotiating on price. And those are the barriers that go from Health Canada approval to actually access for the patients. I think that was your first question.
Okay, thank you. No, that makes sense. I can appreciate that. And then
Yeah.
kind of along those lines, what are the barriers for kind of getting universal germline testing? Like the NCCN guidelines suggest that all incident cases get germline testing. Kind of and we're not in the States, we live in Canada, so kind of what's the data that's needed to make universal genetic testing possible in pancreas cancer in
Yeah.
Canada?
Yeah, so I think great question. So I don't know the status in all provinces. I know that in Ontario, it's BRCA testing is in germline panel testing is funded in pancreatic cancer. I don't know whether there are other provinces that are left behind, and that is more of an advocacy issue that we need to push to get this on the list. The other issue, though, is just at the provider level, remembering that this is something that we need to do, and it should be incorporated as a standard. Now, you can't just do the test. You actually have to talk to your patients. They have to consent to this testing. There are patients who don't want to know. And for a variety of reasons. I've run into this. So you do have to get their consent to go ahead with the testing. And so sometimes that is missed. And I think if we do need to make sure to ensure that this is something that's done in all patients. And I think that we've strategized around that in at the Baker Center to make that as a part of our standard order set and such. So I think those are the two things.
Great, thank you.
Okay. So here we go. This is why this was my next slide. You were looking ahead, weren't you? Yeah, I think from a standards point of view, I think we should be very strong in germline genetic testing being universal. BRCA mutations is common enough in pancreatic cancer that we should be looking at it. has both a therapeutic impact, so how we treat the patient who has a BRCA mutation. These tumors tend to be very sensitive to platinum, and as mentioned, can be very sensitive to PARP inhibitor as well. But it has a clear impact on hereditary cancer screening for those family members that may be affected as well. So having that knowledge is help from an early detection and maybe even a prevention and a standpoint. Now, I think the more debatable thing, I think, is tumor genomic testing, where we're looking at the tumor itself and looking at the mutations that are inherent to that tumor. So this is not a hereditary issue any longer. It is looking and seeing what is making the cancer tick. And as I think you saw from Dr. Gill yesterday, more than 90% of pancreatic cancers or I mean, I can't remember which presentation it was, but more than 90% of pancreatic cancers are associated with a KRAS mutation. Now, that knowledge very well will be helpful as we move forward with having KRAS inhibitors that are in the clinic. So at the next meeting 2 years from now, hopefully we're having some early data about KRAS inhibitors and how that's going to change the game. So having the knowledge of KRAS mutation status is really important. This is why Ontario has made the leap as of October to have genomic testing as standard of care. I think we are the first province to do that, and I'm hoping others will follow suit. Certainly, once these drugs, these KRAS inhibitor drugs, become standard of care, it's going to be a must, but I think we're kind of moving ahead on that. And I think that what is more intriguing for me from the tumor genomic testing standpoint is that the patients who don't have KRAS mutation, there's something else going on there, and maybe we can leverage that. That's where BRAF mutations hide. This is where novel fusion proteins, things like this. So I think that tumor genomic testing, and I think I was talking to Chris, earlier, that if we have tumor genomic testing and we do that for everybody, that may eliminate some of the need for the germline testing. So if you're going to be if you are a BRCA mutation carrier, it's going to be in the tumor, just like it's going to be but there are some patients that have BRCA mutation only in their tumor. So if you find it in the tumor, then you have to check the germline to see if it's a germline test. That's what gets done in ovarian cancer, where the rate of BRCA mutation is much higher. But that's food for thought. But I think that I don't want to complicate things. Germline genetic testing should be done universally. I think we should. I think we want to make that really, really clear. Okay. So just in terms of, I can't believe for the amount of slides that I had, that I've taken this much time. I can talk. Okay. So I think, again, multidisciplinary tumor boards, and we've listed the people who should be involved in these tumor boards. I think you can maybe make the argument maybe that pathology isn't as vital, but radiology, surgery, medical oncologists, radiation oncologists, certainly for consideration of SBRT or neoadjuvant chemoradiotherapy. I think that these are suggestions for those who are involved at these multidisciplinary tumor boards. Again, we talked about the pathways, and maybe these are kind of left to the institutions, to the provinces to be doing, but I think that would be best practice to have institutional pathways, and maybe that can be a standard that you say that you should have. Your institution or your province should have a pathway. A plug for clinical trial participation, and also collecting real world evidence where we can for these patients. Proactive toxicity management, and we've talked today about the assistance of dietitian and pancreatic enzyme replacement therapy, symptom control. We in London do integrate very early with palliative care, and even because of their assistance with pain and symptom management, even the patients that we're pursuing curative intent treatment strategies, we find palliative care very helpful in the management. It's just a matter of how patients are to understand what palliative care actually is. Palliative means make symptoms better. These symptomatic patients, even though they have curative intent, palliative care can add benefit for these patients. So I think that that's something certainly for consideration. Oh, you got to move me again out of the way. There you go. So again, I think implementation checklists, things to be thinking about. I think having local champions in all the different disciplines really helpful. Formally adopting provincial, regional guidelines and protocols, standardizing a pathway. I think patient education is something that is really critical, and maybe this is something that we don't necessarily have to have each region reinventing the wheel on this, but having patient facing materials about the regimens, about supportive care. Just some thoughts about metrics that each of these centers should be tracking: time to treatment, R0 resection rate, outcomes, patient-reported outcomes. I think really, really important.
Jump in there too,
Sure.
like a lot of we look at our digital platforms when you're talking about the importance of patient education and the growth in Erin's group, but also on our YouTube channel, we've had all of these discussions posted, and they're getting thousands and thousands of views. So the patients are interested.
Yeah.
Like we can't track exactly who, but based on, the population that we're, just working with, we know that they want to be educated. There's very few that don't want that education, or their caregivers want that education. So it's certainly, and it was ironic because when we first got our grant for our support group, it was targeting support or caregivers and the health of the caregivers, because we knew that they were rating, like our survey showed, many of them reporting over 20 or 90% showing stress, lack of sleep, exhaustion, but they don't come to the meetings unless it's an educational component so that they can take it back to their loved ones. So even though they're stressed, these people, the patients and caregivers, do want the education and, need it and will use it when it's presented.
And I think that, I think this has given us something to think about locally too, that how patients and caregivers are consuming the information. So what do we do at our cancer center? We give them a stack of paper here. Are they consuming that, or would they do better with, here's a link to a YouTube video that you can watch over and over again? I know that I think if it were me in that place, I probably would prefer the latter. So I think there are different strokes for different folks, but I don't think we're doing a good enough job with the education materials if all we're doing is giving them paper.
And a big discussion around all of this happened at our steering committee for the World Pancreatic Cancer Coalition. And the UK has shown that there's been, I think they said it was a 70% drop in people visiting their websites because people are going to ChatGPT. So, but they're saying like this is, in the United States and Canada, we're certainly talking about what does that mean, because, and they were giving examples in the UK of numerous examples where ChatGPT wasn't right. And instead of, using credible resources from pancreatic cancer organizations and physicians and, resources that we know are to be true. They're now turning to ChatGPT for answers, and they had this huge drop off,
right?
Which is going to impact.
So, my thinking is like, I can understand why people are going to ChatGPT. It's easy. You type in, like, you don't have to, like, where do I find this? Or I have to get on the phone. I have to wait for this. But so I think that it behooves the cancer community if ChatGPT is not giving the information correctly, we need to give some other AI platform that will, so that we make it just as so we make it easy for the patient. And obviously that, this is giving them an answer, but they need to feed back to their care team too. But yeah, we talked about Dr. Google forever, and now it's Dr. ChatGPT.
Yeah, time's changing
yeah.
quickly, so it's how we move.
Okay, I think this is my last slide. Just talking about some barriers and solutions in Canada, just as food for thought. So I think we've mentioned already geography. If we, I think we do feel pretty strongly that pancreatic cancer should be, patients should have access to highly specialized care centers, but the access to those centers is certainly not equitable. If you're a pancreatic cancer patient diagnosed in Nunavut, that's a completely different situation than if you're in downtown Toronto. Chemotherapy reimbursement does vary by province, as we've talked about. And there are barriers of patient fitness, and I think that was a really good mention by Louise yesterday about financial toxicity that patients and caregivers are facing. So how do we address these things? Well, I think that central referral pathways, having nurse navigation, I think is very helpful to overcome some of these barriers of access and communication. Virtual care, when done the right way, can be very helpful. Attention to supportive care, prehabilitation, with physiotherapy, nutrition, and working towards that. I think building networks and harmonizing across provinces is helpful to offset some of this variation. The advocacy that groups like these are doing, and philanthropy, goes a long way to helping the journey of patients in this country. So that all needs to be continued. I think that, key takeaways. So I think this is just a summary of what we've talked about. I really am shocked that I went over time, because this wasn't a whole lot, but thank you for your attention, and happy to take any other questions, unless it's bleeding into the last session of recommendations. Stephanie, where do you want to take this now?
I think it's really helped create the list of recommendations. Yeah, so is there any questions? Or we can go right in, I think it leads well into the takeaways, lead into the recommendations in terms of what are we going to do in the next 18 months. And a lot of what I've been scribbling down, this is all my hen scratches, is to continue on the documents that we started, whether they're called pathways or guidelines or best practices. I think is certainly a huge step in updating the PERT guidelines and getting those released and working with Viatris and the other organizations. But I think that from an advocacy standpoint of how we do this, and I talked to some of the industry partners that have been in attendance, is really whatever we call the person is to hire somebody like a strategic advocate that not only works on the guidelines and bringing all the relevant organizations together to sign off on it and to work with it, and having maybe that, I forget who talked about that 3-day workshop, was a great idea. A lot of work can get done, if we get everyone in a room, but also having that, strategic advocate. I had a bunch of questions for Jim, what that person may look like, with a lot of advancements coming down the pipeline. We could hit the ground running now and be more proactive than reactive when the drug is ready for funding. So I think we certainly need the staff to do that, to help with the guidelines, to help with advocacy in terms of drug funding and regulations, and partnerships, and making sure that all the GI organizations that deal with pancreatic cancer are all aligned, along with the Canadian Cancer Society. Robin?
No, I was just gonna, I'll wait. I'm just gonna suggest that it was around information and AI.
Oh, yeah.
Yeah, so it's really interesting. I'm not trying to promote AI. I'm a little scared around it. So take this, with a grain of salt, but there is actually a lot of work being done around like, just in time information, credible information on how we can use AI in the breast cancer space. Now there is a site, I guess it's an AI bot, Ask Ellen, and it's being evaluated by researchers here in Canada to see how empathetic and supportive and credible and evidence-based it is and whether it works for people. I mean, you can Google it. It's Ask Ellen in the breast cancer, but it's very interesting. I'm sort of following it because I have a bit of panic around it. Again, what people need is just in time, credible information, right? And how do we do that? Anyway, just an example.
Through, like, if you think about the last two and then the Friday night included, what are some takeaways that you would suggest for us as an advocacy organization that we should start working on? So our our steering committees or working groups that we've been working with are represented across Canada. They're multidisciplinary. So what could those teams work on? There'll be new teams, in the coming 18 months. What should they be working on after this 2-day conference? I have, as I said, I've had the pathways, I've had the PERT, I've had aligning more strategic partnerships so that we're collaboratively working on similar projects that have been discussed. We've talked a lot about equitable access. We've talked about drug advocacy, funding. We'll certainly, out of this conference will come a paper, so that'll be one of our next steps as well, is writing a paper about many of the recommendations from each of the guest speakers. But I keep seeing through all my paper, equitability, partnerships, advocacy. Yeah, Lori, do you want to go to the mic?
One thing that hasn't come up this weekend that I'd like to make front and center is it would be great if we can celebrate the long surviving pancreatic cancer patients. Because when my husband was diagnosed in 2017, it was, oh, wow, okay, get your affairs in order. And it was a really dark, dismal time. And this was coming from primary care. And so if we can change that message so that people do know that there are people surviving this, more today than ever. It's still way smaller than it should be, but it's possible. And so if we can maybe highlight that, because I'm not seeing that that any of the organizations are effectively doing that. The champions, I know PanCan does, and they feature people in their
Lori, we've been doing it.
Have you?
Yes, yes. Our strategic plan was, you're right, is that, but people don't just need to hear the stories of survivors. People need to hear the stories of patients that are living with pancreatic cancer and living well. So we started our campaign and we profile, Julian's been working on it, and we profile, it's been Why We Run. So we've had, I think, close to 3,000 participants across Canada participating in the Kicking Pancreas, and we've taken all of their stories. So it's loved ones that are living well with pancreatic cancer. And I think, we know that we're missing a population of about 60% of metastatic patients that are being sent home and getting their affairs in order. So those are the stories that we're telling, that these patients are in treatment, they are living well, they are crossing off their bucket list, they are getting to weddings or births, or, for Dan Fine, his his goal was to get to the run. You know, and he kept saying, you need a backup, Steph, like you need a backup just in case I'm not here for the run. I'm like, you're gonna be there for the run. He was there for the run. So, you know, those are the stories. We're profiling twice a week. In December, we're doing that, but our next 3-year plan is continually telling those stories so that patients aren't scared of chemotherapy. They're asking their you know, their medical team what the treatment options are available to them. We know that through research, you know, patients sometimes aren't told all their treatment options also based on maybe socioeconomic status. So, you know, making sure that our patients are having their stories told is something that we've really been working hard on. I guess we have to work harder.
And maybe I'm thinking maybe to a broader audience, maybe, you know, going on podcasts.
Yeah.
You know, people,
Yeah.
I listen to podcasts. So going on different podcasts and maybe looking at what are the media sources that the general public, because I know people like you and me and all of us in the room, we're on your website. We attend your programming. But that's because we already know it. I'm thinking upstream, the people before they have those first symptoms and end up at the ER. You know, so maybe so that we can get the whole population to know that it's possible. This isn't a death sentence.
Yeah.
So, thank you.
Lori, I think it's a great comment because I think this is, you know, evidence out of Nova Scotia in terms of the percentage of patients diagnosed with pancreatic cancer that never get to see a specialist. You know, that's just not right. And that's coming from the nihilism that's out there that, well, get your affairs in order. There's nothing to do. And so I agree with you. I think that I think it's a multi-pronged approach. I think that we do have to educate primary care emergency physicians better. We have to streamline a pathway of getting patients with suspected pancreatic cancer to specialized care, but we also have to educate the public, you know, and, you know, I think the more stories we can give about patients that are doing well, and, you know, the sad truth is that not all patients do well. And there are going to be those patients that we can't help the way that we do, but we should be giving them the opportunity. And so I think that the more we can work on all of those fronts, the better.
Well, I think our campaign, I know, I don't think, the campaign this month was for us, for Craig's Cause Pancreatic Cancer Society was not trending, not okay. And, you know, some of our slides that Julian has created is no one's talking about it. So you're right in many ways. So we have World Pancreatic Cancer Day Thursday, and when I meet with the committee and go over the results, so we started as 3 organizations and we're up to, I think it was 139 organizations. We know that in the United States, it may trend, but we know in Canada, World Pancreatic Cancer Day and World Pancreatic Cancer Month isn't trending on social media. Hence the campaign that we started. So, you know, and one of our others in our 3-year strategic plan is creating a residency committee. So we've started the discussions. We're not up and running yet, but we're hoping by 2026 it will be up and running, and where we're going in and doing a lot of education in the universities, not just with the residents, but also moving into, we used to do before COVID, in the seats, continuing education programs. So we have a specialist from every province do a continuing education session on pancreatic cancer. So, you know, going back to some of those programs, you know, is certainly in our agenda as well, which could be part of those recommendations, Lori. But, you know, I know we're not trending. I know we didn't trend on Thursday in Canada for World Pancreatic Cancer Day. People aren't talking about it. So there's still a lot of work to be done, not just in Canada, but in other countries as well. And people are finding us, but they find us upon a diagnosis. Yeah, so there's certainly a lot more work to be done in terms of awareness and signs and symptoms and diagnostic pathways for patients even to advocate, but getting the buy-in from, there's still a huge stigma in the medical community about, is it, worth it? I've been part of discussions where they're assessing whether it's even worth, does the Whipple have, enough success to be considered all the time, So there's certainly a lot of, buy-in we have to get from the medical community, not in this room because you guys are here because you're passionate, but outside, general practitioners are being sent CT scans from emergencies. They're being told to go home and get their affairs in order. Patients aren't being offered treatment options or being told about the treatment options, whatever the patient decides, but they should be told all the treatment options available.
Yeah, and I'm going to preface this by saying that I'm a scientist, as most people know, and I always think about the research that goes on behind this. And it's not even about like the molecular biology, cell biology, it's about the patient care. And one of the things that I think you're well positioned to do, because you have connections across the country, is actually look at how practices have changed and be able to come up with data that shows the benefit. And maybe this is a call to Baker as well to do this. We have all of this data of what was like before we established Baker and what it's like now, and be able to say, here is the data to show why this is the best practice or why this is a type of best practice. I'm pretty sure McCain has probably done that. And if they haven't published it, again, that's something that could be put together. And so I would suggest that the organization, because of the position you're in, is to advocate for that kind of information. Because if you go to a policymaker, they're going to be much more swayed by, here is the data, as opposed to a lot of anecdotal information. Because everybody has a story, but if you have the data to back that up, all of a sudden they can't really argue with that. So that would be my suggestion, is that something that the organization should look into coordinating.
And it's something similar, Jim, that you were suggesting as well. Yeah, yeah. So that's a good next step as well. I'm never going to sleep. Anything online, Aaron? Nope. Okay. So on time. What time is that? 12. Bam. There we go. I want to thank all of our presenters. Each of you have been amazing. Taking your weekend to come in and be with us along with all the participants. My team who deal with all we'll do it in a sec. My team that deals with me and did you do this? Did you do this? Did we get this done? Jessica, who's, didn't have her baby this weekend, but she also created this conference and worked really, really hard on it. So Jess, you should be really proud of yourself. Yeah, absolutely. I think, as 2023 did and 2021, we've still got a lot of work to do, but I think having these regular conferences and the working committees in between is the way we can continue to advance, our discussions. Viatris, for the unrestricted education grant, that's really helped us. Lori and Sandy, Sandy was a speaker in 2021 and she was a patient who spoke on hope. So that is on our YouTube and you should watch it. Sandy was all about hope and looking pretty darn good. So she had the best wigs, the best dressed, gal around. She laughed a lot. So a lot of the initial pathways discussions for me started with Lori and Sandy and thinking of flow charts. And we talked about, something we could create online that patients and the healthcare professionals could use. So even though it was kind of a crappy way to get involved in pancreatic cancer 19 years ago, I've certainly met a lot of amazing people. And a lot of passionate healthcare workers that, 19 years ago when we were providing research grants, there was no one interested in them. And now, we're being asked to fund research, and I see all the work that's being done and the tired healthcare professionals still so passionate about their patients. So I want to thank all of you. And Erin, you were going to announce the poster presentations.
And I just also want to add in, Stephanie is an amazing advocate. She's worked so hard for the organization. She's a full-time teacher as well. And yeah, she is incredible. So I just wanted to congratulate our our poster board winners. So we had two really great poster board presentations last night. So one on KRAS mutations and one on the new the poop. I'm sure you guys all know the clinical trial. So really excited to congratulate both Fatima and Daniel for winning the poster board presentations. That's $750 to you. So thank you both so much for your work on that.
And there are some other research grants going to be given out, but I and my team ran out of steam. So we're a little bit delayed in the process, but very soon we'll be able to announce those research projects as well. So again, I know everyone has to hit the ground, but I do appreciate you spending the weekend with us. And thank you. That's it. That's a wrap. Oh, wait, our IT, put up your hands. Our IT team was amazing. So thank you. You did great.